Hi everyone and Assalamu alaikum. This is Dr. Chaman Khan and today we will be discussing hypo and hyperparathyroidism. Well, the learning outcomes of this lecture will be that by the end of this lecture, we will be able to understand the basics of anatomy and physiology of parathyroid gland. We will be able to know the clinical features of hypo and hyperparathyroidism. We will be learning the investigations required to make a diagnosis and the treatment of hypo and hyperparathyroidism. So as we all know that the parathyroid gland location is closely associated with the thyroid gland. Thyroid gland, it encircles the trachea in a semicircular way. And the parathyroid gland, they are closely associated with that. Parathyroid gland, they are actually brownish, small ovoid bodies. They are nearly about 1/2 centimeter in size. They lie within the facial capsule of the thyroid gland. If we recall our knowledge from the anatomy, we know that we have got a total of 4 parathyroid glands, 2 superior parathyroid glands, and 2 inferior parathyroid glands. In this figure, you can see a posterior view. So these parathyroid glands, they are located in posterior relation to the thyroid gland. The superior one, they are related to the middle of the posterior border of the gland, and the inferior parathyroid gland, they are related to the inferior or lower pole of the thyroid gland. Sometimes they lie embedded within the thyroid tissue, or sometimes they are found outside the facial capsule. So their position, it varies most of the time. Regarding the blood supply, the parathyroid glands, they are supplied by the superior and inferior thyroid arteries. We know that the superior thyroid artery is a branch of the external carotid artery, and inferior thyroid artery is a branch of thyrocervical trunk, which arises from the first part of the subclavian artery. The veins are drained into superior, middle, and inferior thyroid veins, lymphatic drainage into the deep cervical lymph nodes, and the nerve supply is through cervical sympathetic ganglion. If we recall our knowledge from physiology, we know that the parathyroid hormone is the most important endocrine regulator of calcium and the phosphate. It maintains the serum calcium levels. There are 3 independent tissues on which the parathyroid hormone acts, and these are bone, kidney, and intestine. This diagram can show you how the parathyroid hormone is released. The parathyroid hormone is released in response to low concentration of calcium in the blood. The low concentration of calcium in the blood make parathyroid gland to release more of the parathyroid hormone. As a result of that, this parathyroid hormone, it acts upon 3 organs, as I have told you earlier, the bone, the kidneys, and the intestines. And what does it cause? From the bones, it causes release of the calcium. From the kidneys, it causes increased reabsorption of the calcium. And from the intestine, it causes increased absorption of calcium from the intestine. So the net result is the increased concentration of calcium in the blood. So initially, since there was a low concentration of the blood, of calcium in the blood. So the parathyroid hormone, it finally maintained and achieved a normal levels by acting upon the three organs, that is bone, the kidneys, and the intestine. The difference over here is that its absorption and reabsorption from kidney and intestine, that is vitamin D dependent. So if there is vitamin D deficiency, parathyroid hormone won't be able to act upon these two organs. So parathyroid hormone, it not only is important in increasing serum calcium levels, but it also decreases serum phosphate levels by increasing its excretion. So they both go opposite way. So parathyroid hormone not only increases calcium, but it also decreases phosphate from the body. So what is hypoparathyroidism? When the parathyroid hormone secretions, they are decreased. So as a result of that, the calcium levels in the body won't be able to be maintained at a constant level. So they will also be decreased. There are certain conditions who can cause hypoparathyroidism. And the most important is following a thyroid surgery. This thyroid surgery can be because of some benign diseases like multinodular goiter or some malignant thyroid malignancies. It follows after total thyroidectomies or near total thyroidectomies mostly, but can also occur with subtotal thyroidectomies. Since we say that most of the time it is embedded within the thyroid tissue and it is difficult to see and localize it because of its small size, it can be removed along with the thyroid specimen, or it can be damaged during the surgery. The second cause can be the parathyroid surgery itself. In the case of the parathyroid hyperplasia, in which we have no other option left than to remove all of the 4 parathyroid glands. Though most of the times we try to re-implant a part of the parathyroid gland, but at times it may prove insufficient and lead to parathyroid insufficiency. Another cause can be autoimmune diseases that can cause destruction of the parathyroid gland. The parathyroid gland can also get affected by infiltration of the cancer from the surrounding tissues, most probably thyroid cancers. And there could be the idiopathic causes as well. So we could have a primary causes of hypoparathyroidism, and we could have a secondary causes of hypoparathyroidism. So how we label these two? We will call it a primary hypoparathyroidism if the disease is within the parathyroid itself, like because of some autoimmune destruction, the parathyroid gland is unable to produce the function, or it is congenitally absent. In the secondary causes of hypoparathyroidism, parathyroid gland itself was normal, but its function was disturbed. Either it got some damage, either because of some radiation or because of some surgery, or in response to low magnesium levels. So we will label it a secondary cause of hypoparathyroidism. The signs and symptoms of hypoparathyroidism will be that of hypocalcemia, because hypoparathyroidism will cause serum calcium levels to drop. So it will manifest as tetany, carpopetal spasm. There could be changes in the ECG in the form of the QT interval prolongation. And we can elicit these signs if they are not present spontaneously And these are the Trousseau sign and Joystick sign. So how you elicit Trousseau sign? In Trousseau sign, you induce a carpopedal spasm by inflation of a BP cuff on the arm, and you inflate it about 20 millimeters of mercury above systolic pressure for 3 minutes. For example, if the systolic blood pressure is 110 millimeters of mercury, you will inflate it up to the 130 millimeters of mercury and keep it inflated over there for 3 minutes. Remember, keep it inflated over there for 3 minutes and then wait for the response. And what response you will expect? There will be the carpopedal spasm. And what is that? There will be adduction of thumb. There will be flexion of the metacarpophalangeal joints, extension of interphalangeal joints, and the flexion of wrist, as you can see on the picture. Another sign is Joystick sign. And again, you will have to elicit it. How you elicit it? You will gently tap in front of the ear onto the facial nerve, where facial nerve enters onto the face. Once you gently tap that, there will be the facial muscle spasm, or there will be the twitching of the eyes or lips on that side. So why these signs? These are elicited, and what they show hypocalcemia. We all know that calcium is an important ion in the nerve conduction, and its low concentration, it causes nerve irritability and muscular spasm. So how do we manage hypoparathyroidism? If it is acute case, like the patient has developed carpopedal spasm or tetany, probably you will have to give IV calcium in the form of IV calcium gluconate. Alternatively, otherwise, you may use calcium supplements in the form of the tablets. You will have to replace the vitamin D levels as well if they are deficient, because I have told you earlier that the absorption of calcium from the kidneys and intestine, that is dependent upon vitamin D. And if the vitamin D is deficient, parathyroid hormone won't be able to act upon these two organs. Then you can advise patient to have diets which are high in calcium, like dairy products, and low in phosphate, like the carbonated drinks, they should not be taken. For neuromuscular irritability, you may prescribe some sedatives to the patients. In hypoparathyroidism, it's not only the calcium levels that are decreased, but the phosphate levels, they are increased within the body. And we need to excrete that, and for that we may need to administer aluminum hydroxide, which will bind phosphate and will help in its elimination. In the case of severe parathyroid insufficiency, naturally you will have to consider giving synthetic parathyroid hormones, but there is a risk of allergy. So now coming on to the hyperparathyroidism. Again, we will see three types of the hyperparathyroidism: primary hyperparathyroidism, secondary hyperparathyroidism, and tertiary hyperparathyroidism. When you call it a primary hyperparathyroidism, when the disease is itself present within the parathyroid gland and causes it to hyperfunction. And what could be that diseases? That could be parathyroid hyperplasia, in which there is diffuse enlargement of all the 4 parathyroid glands. They start hyperfunctioning and they start secreting more and more of parathyroid hormones. The other could be parathyroid adenoma, in which it may involve one gland. There is a local adenoma in one gland, parathyroid gland, and it causes excessive secretion of the parathyroid secretion. Then there could be the parathyroid carcinoma. When you see a parathyroid adenoma in a patient, you should consider it can be a part of MEN syndrome, like multiple endocrine neoplasia. You will have to see whether this is MEN 1 or MEN type 2. In MEN 1, there are 3 Ps: parathyroid adenoma, pituitary adenoma, and pancreatic islet cell tumor. And in MEN type 2, there is parathyroid adenoma along with thyroid medullary carcinoma and pheochromocytoma. The secondary causes of hyperparathyroidism means causes outside the parathyroid gland, which are affecting its efficiency. And there could be chronic kidney disease and vitamin D deficiency. And when you do not treat the secondary hyperparathyroidism, it leads to the development of tertiary hyperparathyroidism, in which the gland becomes autonomous and it is no more under the control of calcium levels. So what is secondary hyperparathyroidism? It occurs when parathyroid hormone secretion is increased to compensate for the prolonged hypocalcemia. So how the hypocalcemia can be prolonged? It can be seen in patients with chronic renal failure, where kidneys, they are unable to convert vitamin D into its active form. And this active form is essential to excrete phosphate. And when this active form is not available, phosphate won't be able to be excreted from the body. And that's why they will tend to increase within the circulation. This excessive phosphate will combine with the calcium to form calcium phosphate. So both these processes, they lead to hypocalcemia and ultimately hyperplasia of the parathyroid tissue, and hence secondary hyperparathyroidism. The tertiary hyperparathyroidism occurs, as I told you earlier, when the secondary hyperparathyroidism is not treated. The parathyroid, it becomes autonomous and it loses every kind of control. And no matter whatever the levels of the calcium are, despite of the high levels of the calcium, it keeps on secreting more and more and more of parathyroid hormone levels. What are the clinical features of hypercalcemia? So here is a very interesting mnemonic, that is bones, stones, groans, and moans. So what do we mean by this? Painful bones. Why painful bones? Because in order to maintain a constant serum level of calcium, the parathyroid hormone will act upon the bones and will cause release of calcium from the bones. So the bones will be weak and they will be painful. The other one, increased serum concentration of calcium. They will cause renal stones, because when the blood, which is laden with increased calcium concentration, they will reach the kidneys, there are chances that it may precipitate there in the form of stones. Abdominal groans. Because of the excessive hypercalcemia, there could be GI symptoms in the form of nausea, vomiting, and constipation. And there will be psychiatric disorders like psychic moans. There will be effects on nervous system, lethargy, fatigue, depression, and memory loss. So I hope this mnemonic is very easy to remember. Painful bones, renal stones, abdominal groans, and psychic modes. This picture shows how excessive levels of calcium in the blood, they can affect other organs as well. Like they can cause pancreatitis and they can cause peptic ulcer and muscular atrophy. What investigations you will like to carry? Naturally, you will like to get serum calcium levels, serum phosphate levels, and parathyroid hormone levels. And how you will come to know that this is a primary hyperparathyroidism or the secondary hyperparathyroidism? In the primary hyperparathyroidism, both the calcium and the parathyroid hormones, both will be high and phosphate will be low. But in the case of the secondary hyperparathyroidism, parathyroid hormone level will be high, calcium level can be normal, and phosphate excretion will be increased. The other investigations, you will like to have a raised, you can find a raised alkaline phosphatase level. It's important that you also get the vitamin D levels. It's important to get the bones density, to check the bone density by DEXA scan. Then certain radiological investigations, like you need to have an X-ray of skull, of spine, of phalanges, of jaw. You can take help of the ultrasound neck to localize if there is a parathyroid adenoma or if there is palpable swelling and it is palpable. You can take help of the CT scan and the MRIs. And in the difficult cases, you can have a thallium technetium subtraction isotope scan, which is also called system AB scan. And it can help you actually localizing the difficult parathyroid gland if it is not located at the normal anatomical position. It may help you. Again, you can have a selective angiography or venous sampling in the case of the difficult parathyroid locations. So the X-ray, which you will like to get, X-ray skull, X-ray phalanges, X-ray jaw, X-ray spine, and there will be characteristic features on these X-rays, which I will show you in the coming slides. So what are the effects of hyperparathyroidism on the bones? It causes excessive bone resorption. It decreases the bone mass. It results in osteopenia, and in severe cases, we call it osteitis fibrosa cystica when it involves nearly all the bones of the body. So here you can see a normal skull X-ray on one side, and on the other side, you can see an X-ray of a patient with hyperparathyroidism, and you can appreciate a salt and pepper appearance of the skull. Out in the white background, you can see radiolucent areas of various sizes which are scattered all over the skull. We call it salt and pepper because it's just like if you mix salt and a crushed pepper, the salt particles will be smaller and the pepper particles will be a bit larger. So they will give an appearance like this, as you can see in this radiograph. So that's why it's called salt and pepper appearance of the skull. And the reason is excessive resorption of the bone, excessive osteoclastic activity of the bone under the effect of parathyroid hormone. So how it affects long bones? Here I have put an X-ray of the long bone, the tibia. On one side, you can see the normal tibia. On the other side, you can see if some chunk of the bone has been scooped out from the tibia. And this is because of the localized excessive osteoclastic activity and bone resorption. We call it brown tumor. Actually, it's not tumor, but it's called brown tumor because it looks like some osteoclastic tumor. How it affects phalanges. Again, on one side, you can see the normal X-ray in which you can see radio-opaque bones of phalanges. And on the side, you can see the phalanges in which they are more radiolucent in the center, and there is excessive subperiosteal bone resorption. Hyperparathyroidism also cause tapering of the distal end of the clavicle. You can see the normal clavicle on one side, which and you can very clearly identify its clearly demarcated distal end. But on the other side, you cannot appreciate a clear-cut end. You don't know where the clavicle ends. There is tapering, or the distal end is not very clear. Then how does it affect spine? It's, the typical spine is a rugger jersey spine. It appears like a sweater, striped sweater. And again, the reason is subchondral bone deposition and the excessive bone resorption in the center. So it gives a classical light and dark appearance of the spine. And that's why it's called rugger jersey spine. So how you treat hyperparathyroidism? Initially, you give the medical treatment. It's important to hydrate the patient to prevent any precipitation within the kidneys and to prevent constipation. So excessive hydration in the form of the oral fluids or even IV fluids that are required. You will have to give diuretics. Here, the loop diuretics, furosemide diuretics, they are a better choice. You avoid thiazide diuretics because they cause they decrease the calcium excretion, and we don't want this. We actually cause excessive calcium excretion. The same way you give the patient advice to decrease calcium containing diets. Bisphosphonates, which are used to treat osteoporosis, they may be given in an attempt to decrease bone resorption. And if vitamin D deficiency is there, you should treat that as well. So if is vitamin D deficiency, you should give vitamin D supplements. But if there is no vitamin D deficiency and the parathyroid hormone levels, they are the calcium levels are high, and okay, this is that how you will go for treatment of the parathyroid hormone levels. Once you have sorted it out, that what is the location of the parathyroid gland, you have treated it medically, you have pre-operatively, you have localized it by ultrasound or by system AB scan. Then you may go for surgery if there are persistently high levels of parathyroid hormone levels. So what surgery you will do? You will go for a parathyroid excision if there is a parathyroid adenoma, and you will remove all the 4 parathyroid glands in the case if it is a parathyroid hyperplasia. And then you will reconsider some part of that parathyroid gland to retransplant into stenomestate tumor. Otherwise, it will lead to parathyroid insufficiency. But if it is malignancy, then naturally you can't do this, and you will have to consider long-term parathyroid hormone administration, synthetic ones. So that's all for today. Thank you for watching this. See you next time.